So we're going to talk about just a little bit of a review of the anatomy and physiology of neuro so that can help us understand what's happening with some of our patients who have these neurological disorders that we're going to talk about. So what are the two types of neurons? This is stuff that you should remember from A&P in terms of their function. Motor and sensory. So what do the motor neurons do? Facilitate movement. And the sensory neurons facilitate sense. Okay, excellent. Now, how are the nerve impulses conducted? How do the nerve impulses go? How are nerve impulses go, like from your brain to tell you, the rest of your body, what needs to be done? What's the process? They go from neuron to neuron, right, across the synapses. Okay, and inside the synapses are neurotransmitters. Various neurotransmitters that we're not going to get into all the details of what each one is at this point. But certain things can affect the neurologic conduction of impulses if we have too much or too little of certain neurotransmitters. They can cause problems. And some of the diseases that we're going to talk about are going to be problems with the levels or the lack of certain types of neurotransmitters. And certain conditions within the body can affect the transmission of those impulses across the synapses. Things like acidosis, which will cause a decrease in the transmission, or alkalosis, which can cause an increase or a speeding up of the impulses. So just like when we talked about cardiac conduction, and everything has to go in a nice orderly rate and not go outside of the pathway. With neurological conductions, we've got to have the proper levels of neurotransmitters. We've got to have a stable homeostasis going on in the patient's body, or those nerve impulses can be impacted. What about the cerebral circulation? Who can tell me what the circle of Willis is? What's that? What were you waiting for? What you talking about, Willis? So we have our carotid and vertebral arteries that form a circle at the base of the brain that provides circulation to the brain. So if we have problems, malformations, aneurysms, congenital issues with that cerebral circulation in the circle of Willis, that can cause some neurological problems. The carotid and vertebral arteries, they form a circle at the base of the brain, which is why they call it the circle of Willis, and that's what provides oxygenated blood and a proper circulation to the brain tissue. So if there's problems in that circulation, we can have strokes, we can have aneurysms, we can have other problems with our neurological function. What do we say the parasympathetic nervous system does? Parasympathetic. Rest and digest. So it counteracts the effects of the sympathetic, which does what? Fight or flight. Read the question carefully, or listen carefully to the instructor. You all thought I was going to say sympathetic, didn't you? Yeah. So sympathetic, fight or flight. Parasympathetic, rest and digest. So what happens when the sympathetic nervous system kicks in? Heart rate goes up. Blood pressure, up. GI motility, respiratory rate, good. Now this is kind of an interesting picture, not an interesting respiratory link, but what I'm going to have you do is look at this picture and tell me, or think to yourself, and then I'll ask you what you see, which direction she is turning. Is she turning clockwise, or is she turning counterclockwise? So look at it for a bit, and then I'm going to ask for a show of hands. Okay, who can see her turning clockwise? Who can see her turning counterclockwise? Who can see both? Can anybody see both? Or can you make her change? Okay, I can only see her turning clockwise. And some people can only see her turning counterclockwise, and no matter what you do, if you look away, if you look at a different part of the picture, she's still turning that same way and you can't make her change. Other people can make her change direction. What happens is if you can only see her turning counterclockwise, clockwise, you are using your right brain. If you are right-brained means you are random and intuitive and holistic, and you see the big picture and sometimes not the details. So artistic people tend to be right-brained. Now, if you see her only turning counterclockwise, then you are predominantly left-brained, which are the logical, sequential, rational, looking at the parts of the whole kind of thing. If you can, primarily what happens is that if you're right-handed, your right hand is controlled by the left brain. So if you're right-handed, most right-handed people are predominantly left-brained, and most left-handed people are predominantly right-brained. I'm left-handed. I was also very musical growing up and very creative, so I am predominantly right-brained. I cannot make her change position. Some people who have started off one or the other but have taken jobs or have, or hobbies that require them to really use the other side of their brain are now able to kind of look at it and see her going in both directions. Yeah. Now, what, are you right-handed or left-handed? For those of you who are switching, right-handed or left-handed? Right-handed? Right. But it's like no matter what I do, no matter where I look on that picture, I can't make her change position. Yeah, that too. So that's just kind of an interesting thing that you're going to see, and how bizarre and unique and amazing our brain is. I've almost had fist fights break out in classes, in arguments over this picture. So let's move on. Okay, neurological assessment. You seeing a pattern here? We talked about cardiac assessment. We talked about respiratory assessment. The elements of a neurological assessment. So what questions are you going to ask your patient who's coming in with neurological issues? Do you know where you are? So you're assessing level of consciousness and cognitive ability. But what other types of questions might you ask in terms of like their history? When did it start? What'd you have for breakfast? But what's really important to know with some neurological issues? Headaches, family history. A lot of neurological conditions, there'll be family tendencies where your risks are increased if other members of your family have a particular condition. There's actual genetic mutations that can cause neurological deficits and diseases. So knowing what the family history is going to give you a lot of information as to what might be going on with this patient. And then you're going to be asking questions like Vaughn said, do you know what day this is? So there's different types of mental status questions that you're going to be asking. Whether they can have good short-term memory, if they have good long-term memory. Immediate recall and that sort of thing. Pain sensation. As part of your physical assessment, you need to make sure that they can feel pain on either side and equally on both sides of their body. What other types of things in that physical assessment are important for you to know? The Glasgow coma scale. So that includes your pupils, cranial nerves. If you were, working in a neuro floor and you're going to be doing a complete head-to-toe neuro assessment, then cranial nerve assessment is going to be important, and we're going to talk about those in a little bit. But the key thing that you always have to remember with neurological is that your baseline assessment is critical. Patients with neurological injuries, conditions, traumas, any kind of thing going on neurologically, things can change very, very subtly, very, very quickly. So if you know what your patient's baseline is, then you can tell if there's a problem developing. Because the key with a lot of neurological issues is catching it before it gets into something that is going to be unmanageable. Exactly. Well, that's a whole other, part of the whole story there. So some of these neurological assessments, we talk about hand grasp, we talk about listening to patients' speech, their level of consciousness. All of those are going to be really important to have as a baseline. So if you're that admitting nurse, getting that patient in with a new neurological diagnosis, doing a thorough assessment and documenting their baseline abilities in all areas, their gait, their hand grasps, their speech, and being very detailed when you do these assessments and document them so that everybody following you can see if there's a problem, if there's a deterioration or a change. Yes?
Can you do the Cincinnati stroke scale? Would that be an appropriate?
It'll depend on what they're admitting diagnosis. Obviously, if they're coming in with a stroke, you're going to use whatever stroke scale your particular facility might be using. So Cincinnati is one of them. There's a lot of different stroke scales, and most facilities, you know, when you go back to wherever you're doing your clinicals over the next couple of weeks, see if you can find out if they have a specific stroke scale that they're using, particularly in places like St. Francis, where and if you're on 8-7, there should be a lot of forms that you're going to be using for that type of assessment. Who can tell me what the Romberg sign is? Anybody know what the Romberg sign is? And like I said, I know you haven't done. What? It tests balance. And what the Romberg sign does is tests equilibrium. And it says, okay, patient is standing there, and you have them put their feet together. I'm going to stand. It's going to be interesting. And you have them put their feet together and their hands at their side. And when their eyes are open, they should have good balance. But if they're having problems with proprioception, and what is proprioception? Right, knowing where you are in space, keeping your balance. If they close their eyes when they're in this position and they're having difficulty with proprioception, they're going to sway. Because one of the ways that we compensate for problems with proprioception is we focus on things like, you know, static things like the horizon, like, you know, stationary objects. And it's an unconscious way that we compensate, but if you close your eyes, you don't have that visual compensation. And so that patient with balance issues is going to start to sway. Now, I had issues with equilibrium and with vertigo a couple of years ago, so I am not going to let go of the podium when I close my eyes, because I don't know what might happen. So when I close my eyes and my hands are down at my side, I should stay without swaying. And I may not even be aware of the fact that I am swaying because I have problems with proprioception. But the nurse is going to be able to see that. So if you have a positive Romberg sign, the patient is going to sway, they're going to lose their balance when they close their eyes, when they're standing with their feet together and their arms at their side. So you always want to be right next to that patient that you're assessing with the Romberg sign, because if they start to lose their balance, you'll be there to catch them. So, okay. Babinski sign, you all know about that because you learned it in OB, right? What's the Babinski? Right, if you scrape up on the plantar surface of the foot, if the patient is under 2 years old, the toes will splay out. If the patient is over 2 years old and the toes splay out, we have a positive Babinski, and that's a bad sign. That is an indication of neurological deficit. So what should the patient do if they're over the age of 2? They should curl their toes. So that's going to be part of that neurological assessment that the doctor is going to be doing to determine where there might be some issues neurologically. So that adult patient with a positive Babinski, where the toes splay out, then you've got some neurological problems. So now we're going to go to the cranial nerves, and I know you learned all these in anatomy, and you probably all learned certain mnemonics, you know, memory aids to remember whether they are, you know, the order of them, and also whether they're sensory or whether they're motor or they're both. And the handout that I have posted on Blackboard gives some, and then there's another one that's vaguely pornographic that other people have learned. And if you don't know I don't know what it is, I've just heard it, so I can't repeat it to you, but you could always ask a classmate to explain to you that. But what you will need to know for the NCLEX oftentimes will be, you know, what specifically that nerve involves, whether it's sensory or motor or both. On my exams, I will give the number of the cranial nerve and the name. So you will have however you decide to learn these, but I can't guarantee that the NCLEX will not just put up either the name or the number and expect you to know what they're talking about. So for my exam, learn it whatever way you want to learn it in terms of number or name and what it does. But for the NCLEX, make sure that you know both, because like I said, I don't know what they're going to do in terms of their questions. So, olfactory, what type of nerve is that? Sensory or motor?
Sensory.
It's sensory, and what does it involve?
Smell.
Smell. How about your optic nerve, sensory or motor? Sensory. Optic, and what does that involve? Your eyesight, your vision, your visual acuity, central and peripheral. How about oculomotor, sensory or motor? Motor. kind of obvious. And what does it involve? Eye movement, specifically your eyelids and your pupils. So when you're doing your neuro checks and you shine that flashlight into the patient's eyes to check for pupil reaction, you're checking for the function of the oculomotor nerve. How about the trochlear, sensory or motor? It's motor. And what does that involve? Eye movement. And what that does, it's your eye movement looking down and looking in. So when the doctor's doing those eye exams, those neuro checks on you, that's where they can tell whether or not you can, literally cross your eyes or if you can look down. So that type of movement. How about trigeminal? Sensory or motor? It's both. So if it is the sensory part of the trigeminal nerve is your corneal reflexes, your face, scalp, and mucous membranes. The motor aspects of the trigeminal involve chewing. Now the abducens, motor or sensory or both? It's motor, and it's eye movement laterally. So looking side to side. Yes?
The sheet that you gave us,
Yep.
the fourth one, what is it, trochlear?
Yeah.
It says that it's motor and sensory.
It's a trochlear, motor and sensory? It does say that? Let me see. Can I see? No, if you look over, trochlear is M for motor. Trigeminal is B for both. Trochlear, towering, money. If you look across, oh, the one for the brain, that's a fill in the blank. That's not going in order. Yay! Yeah. Now, the other one is where they're asking you to identify them based on what they're talking about. This is the list that says whether they're sensory or motor or both. Okay, so we did trigeminal. Now we're doing abducens, lateral movement, motor. Facial nerve, sensory, motor, or both? Both. So the sensory part, pain and temperature from the ear. The deep facial area, taste, can be affected by the facial nerve. And the motor aspects of the facial nerve are your muscles of your face and your scalp, so facial symmetry. That patient that's had a stroke and they have facial droop on one side because they have involvement of their facial nerve. Salivary glands, tear glands are all going to be affected by the facial nerve. Acoustic, sensory or motor? Sensory, for both hearing and equilibrium. So that's the one that you're testing when we do that Romberg. Your equilibrium, your proprioception. Glossopharyngeal, sensory or motor? Both. So for the motor part of it, there's swallowing, throat muscles, the parotid glands. The sensory, along with the vagus nerve, is going to be involving your gag reflex. Taste, pain from the ear area. So glossopharyngeal, glosso meaning tongue, pharyngeal meaning pharynx. So swallowing, think of swallowing with that, and gag reflex. The vagus, sensory, motor, or both? Both. Sensory, we're going to have, again, pain and temperature from the ear area, pharynx, larynx, thoracic and abdominal viscera, all of that is sensory. That's why when you talk about the vasovagal reflex, that's part of that sensory part of the abdominal and thoracic viscera. The motor, very important with stroke patients, for example, swallow, gag, and cough reflex. So if the vagus nerve is involved, patients are going to have problems with swallowing. They're going to have problems with aspiration. Spinal accessory, motor or sensory? Motor. And that's going to be your neck strength, your ability to shrug your shoulders. So that's, again, part of that neurological assessment where they're asking you to shrug your shoulders to see how your cranial nerves are working. And finally, the hypoglossal, motor. And it's the skeletal muscles of the tongue. Now, when you stick your tongue out, if your hypoglossal is working properly, it should go out straight. But that patient who has neurological damage, they stick their tongue out. They think they're sticking it out straight, but it's deviating off to one side or the other. And then there's a couple of cranial nerve diseases that might show up on an NCLEX. They're kind of popular and very common. There's trigeminal neuralgia, problems with cranial nerve 5, or facial paralysis, Bell's palsy, with cranial nerve 7. Both of those usually happen when you've had some sort of inflammatory process. Ear infections can sometimes cause one or the other. Traumas and infections that happen in the mouth that might work their way up into the central nervous system. And in trigeminal neuralgia, patients will have intense pain and spasms of that nerve, to the point where patients who have experienced this, a kidney stone, and unmedicated childbirth have said that this is worse than the other two put together. Intense pain and spasms. So patients, for medications to treat this, will be given things like Tegretol, Neurontin, things that will reduce the nerve irritation. Antispasmodics like baclofen, which you'll see being used on patients with MS, that we'll talk about in a little bit. Or they may have to have an injection of phenol into that irritated nerve, or surgical decompression of the nerve. What will happen with Bell's palsy or facial paralysis, again, oftentimes after ear infections or mastoiditis, patient will have a weakness or a complete drooping of one side of their face. They'll have pain, and conservatively we'll treat them with things like antivirals, cortisone, prednisone, and a facial sling if it is so severe that just to enable them to keep their eyes closed and their mouth closed, they may wear a facial sling. And many patients that have had this will have some residual facial droop even after it's resolved. So who can tell me about the Glasgow coma scale? What are the elements of it? So we have eye-opening points. So what are we looking at? What's the gamut? What's the spectrum of things that we're looking at? Right, so do they open up spontaneously? Do they only respond to voice or painful stimuli, or do they not open their eyes to any stimulus at all? I will not be asking you the specific numbers, what each one stands for, because that's not something you have to memorize, because when you do neuro checks, you have a checkoff list in front of you or a computer in front of you that tells you what number to assign. If you were going to be neuro nurses and you're going to be neurologists, obviously you'd have that all memorized. But I will not ask you, okay, if it's this and it's this and it's this, what's the total number of points? I think that's kind of ridiculous. Verbal, patients will respond spontaneously, they will respond with confusion, with garbled speech, or there'll be no response at all. So they will run that gamut. And motor responses will go from, patients will obey commands to move an extremity or do a particular action. Others will only be able to localize and move when pain pain stimulates them, but they still move appropriately with pain stimulus. Others will have non-purposeful movements. Others will have abnormal posturing that we're going to talk about when we get into increased intracranial pressure. And others will have no response to pain. So just knowing that, that's part of our neurological assessment to determine how severe that neurological injury is for that patient. And I'm going to stop here because I don't want to get into the diagnostic tests because that's something that you need to read up on. You're welcome.